PhD thesis defense. And as you just saw in your window, I assume this is being recorded. We'll have mechanisms for you to ask questions. During the presentation, if you send me a chat message, then Brian's given me permission to interrupt him. If it's a clarification question, we'll try and keep the longer, more detailed and more interesting questions to the end. But if there's something that comes up in the meantime, you really feel the need to get it answered in order to keep following along, then please, like I say, just send me a chat and we'll deal with it. It's always a pleasure to be able to see another PhD candidate reach this stage of the process. It's always fun then to look back a little bit. And I actually found the initial email that Brian sent me back on December 6th of 2011. And that's not that his PhD took that long. Please don't get that incorrect assumption or impression. So Brian emailed me back in 2011 as a freshman and said he was interested in research. I think as it turned out, that was sort of a nominal interest. I think he realized, well, I got to do research, because it's part of the biomedical engineering training program. I have no choice, but I'll do something simple and won't take me too much time. So he reached out to me, which was his first mistake. And his second was getting drawn into the research and genuinely interested in the research. And I think his fascination turned into a transformed academic pathway through the MD PhD program. And that's why it's 10 years since he not only completed his undergraduate program, completed his first 2 years of medical school, but has now also completed, or hopefully today will complete, the formal requirements for his PhD. So he's been on an aggressive timeline and also achieved a lot, great deal really along the way. And during his graduation as an undergraduate, the commencement ceremony, he actually gave the speech. A student is selected every year to give a speech to represent his graduating class. And it was maybe extremely prescient at the time, because I remember well that Brian spoke then about the importance of vaccinations. And that even then there was resistance to vaccinations, obviously long before COVID-19. And so he knew even then that vaccinations were going to be an important aspect of public health, of worldwide health, and made that the centerpiece of a really impressive presentation, which we even have the video somewhere around in the university. So if you wanted to watch it, I think that's still available. So with no more delays, like I say, the sort of game rules here are the ones I explained. If you have questions, send me a chat. We'll have a question period at the end, and then be able to unmute you to ask questions. If you want to just send me a question, I'm happy to read that question at the end. But I would say with no further ado, let's give Brian the floor and let him tell us about his research and what he's been doing for the past 4 years.
Thanks so much for that introduction, Rob. I believe everyone can hear me okay and see my screen correctly. Awesome, spectacular. We're going to start today by discussing this topic of experimental examination of partial occlusion acute myocardial ischemia. And to be honest, we're going to start the story with my wardrobe choice today. So as you can see, I'm actually wearing something surprisingly relaxed in that I'm in a vest and a hat. And I think most people that have seen dissertation defenses before would say I'm a little too relaxed in what I'm wearing. And for those of you that know me, you know that this is kind of my typical attire. So some might ask, why am I so casual today? Well, I want to begin with a quick story. So Rob mentioned that email that I sent in December, and so I met him in December. It was actually during the off break of my freshman year in the BME program, and I was really nervous walking into his office, and so I put on my nicest shirt and tie, and I went upstairs. And as I'm walking down the hallway, I noticed that nobody else was wearing a shirt and tie. Seemed like everybody else was wearing shorts and a t-shirt. And then I rounded the corner and entered Rob's office. And Rob was sitting there in his bike gear. And from then on, I've been instructed that sometimes the nicer I look, the less serious people take me. So in this environment, here's where I'm at, and this is what I'm doing today. I also want to note that today I'm wearing a hat. Our close collaborator, Dana Brooks, would say all is right in the world when Brian is wearing a hat. And I wear several different types of hats, depending on the weather or if I wanted to match my shirt or not. But I think this would lend itself nicely to what I feel like I've designed and developed over a long period of time through the MD PhD training, in that I've created expertise and developed several different hats to wear. So specifically today, we're going to talk about 3 of the hats that I think are important in terms of understanding our understanding of cardiovascular physiology and how things are happening. Specifically, we're going to talk about my engineering hat. This does not suggest that I can actually build anything, let's be clear, in terms of my engineering skills, but engineering in terms of signal processing and important electrical functions. Also, the clinical hat. So I did the first 2 years of medical school, which gave me a great background on kind of the clinical pathologies and what's really relevant, as well as mentorship with clinical mentors. And then finally, the scientific hat. And I couldn't think of a really great science hat. So we're going to go with the scientific goggles that will represent. And so, you know, developing all of these hats has been a really fun challenge, but some people might ask, why do you need all of these hats? You know, cardiovascular physiology, like, it can't be that hard. It's just the heart's a pump. And in fact, one of my MD PhD colleagues that will go nameless here used to say, well, why the heart? It's just a pump. It can't possibly be that complicated. And while I fundamentally agree, the heart actually has some really complicated components to it. First of which are the specialized cells called cardiomyocytes that function very differently than any other cell in the body. Second is the fact that the heart is innervated by the brain. Obviously, as we feel things or see things or do things, our heart changes based on parasympathetic or sympathetic activity. The heart's also innervated by hormones, such as that fight or flight response we get as we want to run away from something. The heart and cardiovascular physiology is highly regulated by kidney function. And in fact, many cardiovascular physiologies are segregated based on whether or not you have chronic kidney disease. The lungs are another key part to the heart, i.e., as lung pressure changes and pathologies in the lung change, you get significant effects on the heart. The heart is also fundamentally a mechanical organ, and it has these mechanical valves that open and shut. These valves can damage over time. And not only is the heart a mechanical organ, but especially today, what we're going to highlight is the heart's an electrical organ as well. And what I'm showing here is an example of the 12-lead ECG that we would get an example lead of the electrical activity recorded on the torso surface. And that electrical activity initiates because of changes to cells or action potentials in cells. And these action potentials are governed by a series of different ionic currents that we're not going to go into great detail today, but again, noting that all the way down to the cellular level, we have electrical function. We also want to note that the heart is affected by your overall exercise, like going outside and doing something, your heart rate changes. And if you're scared, worried, again, that fight or flight response. And then finally, we have the vasculature. The heart perfuses the entire body through this complicated network of vasculature, and it also perfuses itself. So I hope that gives a good perspective as to why we need all these different hats. But today we're going to talk about one pathology in specific, acute myocardial ischemia, and some of the complexities of all these interactions and how this happens. So what exactly is acute myocardial ischemia? So putting our clinical hats on, acute myocardial ischemia is this common complaint of crushing chest pain. And this typically is caused because patients come in and they say, I've had like this chest pain and it hurts really bad, and they present to the emergency department. And usually they're extremely worried. And so subsequently, they get worked up for a whole slew of different things. In fact, that's the most common reason for someone to present to the emergency department. So what exactly is happening during these ischemic events, and what is causing the ischemia? Well, if we think about ischemia in context of the heart, we see that we have a nutrient supply and a metabolic demand. And specifically, in normal cardiovascular physiology, the nutrient supply and metabolic demand is roughly equal. However, in the case of ischemia, there's actually a metabolic imbalance where the metabolic demand increases and the nutrient supply decreases or stays the same, subsequently tipping the scales and causing acute ischemia within seconds. This is when chest pain typically starts to develop. So who would be kind of the person or patient population that might have this happen? I think a typical scenario, especially in the state of Utah, is somebody who remains relatively sedentary, but then one day decides that they're going to shovel by hand their 300-yard driveway with 12 inches of snow on top. As they get into the shoveling, their chest starts to hurt. And usually you can just kind of stop and relax and the chest pain will subside. And that's an important component of acute ischemia in that it's a entirely transient episode, i.e. you can continue to perpetuate it, or you can stop the exercise and the heart will return to its normal levels of function. And also the patients are able to completely recover during this ischemic state. Now, just to kind of round out our picture here, a lot of people have heard of heart attacks before, or a myocardial infarction. This occurs when acute ischemia is prolonged within the hours phase, and usually when there's a complete constriction or loss of all nutrient function. This is a completely irreversible function, i.e. you develop scar tissue and tissue that you can't replace in the cardiomyocytes. So, as you can imagine, it's important for us to detect ischemia early and often. In fact, patients with acute myocardial ischemia are higher risk for cardiac arrhythmias, as well as determining what the underlying condition is as to what's going on to the patient in that time period. And fortunately for us, we can examine the cardiac function in context of a 12-lead ECG. And these 12-lead ECGs are these torso electrodes that we can place across your body surface, and we can measure the electrical activity non-invasively from your heart. As shown here, this is the simplest kind of version of an ECG, and we're going to walk through what the components of the electrical function of the heart are. Specifically, when we look at that ECG as we looked at before, there are three major components. First is the P wave, second the QRS, and then the T wave. Many of you probably know that the P wave will correspond to activation of the atria. The QRS complex corresponds to electrical activation of the ventricles, and then the T wave corresponds to a repolarization of the ventricles. But what are we looking at in the ECG in order to detect acute myocardial ischemia? Well, when we look in the ECG, there are several things that happen, but today we're going to focus on changes to this ST segment. There could be changes to conduction and the T wave, but again, today we're going to focus on this ST segment. In normal electrophysiological function, we see that the ST segment should sit around 0 potential. However, in the case of acute myocardial ischemia, for some reason, there is current flowing between healthy and ischemic tissue. And that current causes a change in the measured ST segment potentials on the torso surface, subsequently creating a depression or an elevation, depending on where the ischemia is and where your electrodes are located. However, we discussed that ischemia is a transient and recoverable phenomena. And in fact, many people present to the emergency department after the chest pain has subsided. So what can we do to detect it if it's no longer there? The answer is we can stimulate your heart like you did. And quite simply, we put you on a treadmill and expect you to run while we're monitoring your heart's overall activity. And this is called a cardiac stress test. In the case that you are unable to exercise, we can also administer a drug called dobutamine to stimulate your heart activity in order to examine how these electrical signals are changing over time as we continue to increase the stress on your heart. Despite all of this testing and sound logic, the detection of acute myocardial ischemia with ECGs still isn't that great. In fact, The sensitivity is between 50 to 72%, and the specificity is somewhere between 70 and 90%. It's important because, one, we need to detect whether or not you have ischemia. Obviously, we don't want to send a patient home who, who has ischemia and we told them that they didn't. That's a big issue. But the second issue is that we don't want to say you have ischemia and then accidentally put you at risk for the interventions that we would do down the line. Some of these interventions are highly invasive and we don't want to put patients at risk. Therefore, this brings us to the goal of this project, which is to improve our understanding of acute myocardial ischemia development and provide clinical insights to better detect these electrical changes. Therefore, we designed the project with the following 3 specific aims. First, in aim 1, we want to extend an animal model of ischemia to measure the electrical potentials within the myocardium, on the heart surface, and on the body surface during controlled ischemic stress. Next, we want to test the hypothesis that exercise and dobutamine infusion create different regions of myocardial ischemia. And then finally, we want to assess the transient recovery of ST segment deviations on remote recording electrodes during a partial occlusion cardiac stress test compared to what we measure going on inside the heart or the intramyocardial ST segment deviations. So using our multiple hats, we're going to contribute to the field by increasing our understanding of ischemia. We're going to start by wearing our engineering hat. And so jumping into kind of some background here on this first aim, previous experimental models have done something similar before. In fact, several studies have been performed relatively recently where there were measurements from the epicardial surface of the heart and on the torso surface, as shown here, and in this image on the right. Now, these were extremely useful to the field in terms of understanding how electrical propagation from the epicardial surface goes to the torso surface and what important parameters we should be considering when we're looking at our torso surface recordings. But there were some things missing in context of the application to acute myocardial ischemia. First and foremost, can we control the amount of ischemia present? Can we create a model where we can control and adequately vary the amount of ischemia that we see? And then second, what's going on inside the myocardial wall? Something that's really important in this in the context of ischemia is understanding not only what's going on the epicardial surface, but this ischemia can present anywhere in the myocardial wall, and you may not be able to see it on the epicardial surface. Some of our previous work and work that was done before I arrived in the lab had already made significant progress in this specific problem. The development of these intramural plunge needle arrays and an electrode sock allowed us to measure on the epicardial surface and within the myocardium at the same time. You see these intramural plunge needles that were placed inside the heart with 10 electrodes down the needle. That allowed us to measure what was going on inside the heart. And as you can see, many of these plunge needles were placed along with our epicardial sock. And then we were able to vary the amount of perfusion to a specific region of the heart using a hydraulic occlusion device. This model was extremely important and gave us a lot of important novel insights in terms of how ischemia was functioning and developing through time, but it didn't provide some of the translational components that we need in order to use this to provide clinical insights. Therefore, we set out with this aim with several requirements for a comprehensive translational model of ischemia. The first is simultaneous electrical recordings from within the myocardium, on the epicardial surface, and on the torso surface. Second is accurate and precise locations of electrodes and overall gross anatomy. And then finally, we need to be able to control myocardial ischemia. Looking at the first goal, we need to measure all these recordings and we need to modify our intramural plunge needle arrays. And we did that using novel state-of-the-art three-dimensional printing that we were able to create these needle plunge arrays. We also placed our epicardial sock. This is a 247 lead or 247 electrode epicardial sock around the ventricular surfaces. And then once we were finished placing this equipment on the heart, we were able to close the chest surface and have recordings from the torso surface as well. Next, we needed to record from all of these electrodes. As you can imagine, we end up with somewhere on the order of 500 to 1,000 individual electrodes we need to record. And to do that, we actually updated our current multiplexing system in order to record from our custom arrays and filter protect us from potential electric shocks in case we need to shock the heart or something coming from a surge, and correct the amplitudes, and then feed that into a commercial system, which did the A to B conversion and subsequently record on a computer system. Now, it's extremely important that we updated our system to do this. However, almost equally as important is when we get to update our photos, as seen here. This initial photo of our 1999 multiplexer model, as well as our 2020 multiplexer model. So now we've recorded all of our signals from the needle, sock, and torso. So what's next? We actually need to process these signals and filter these signals to make sure we know what's going on. And we did that using our in-house developed toolkit called the Pfeiffer toolkit. Specifically, Pfeiffer is able to filter these signals, and then we can use the tool to isolate specific regions of interest in these signals across all of the leads simultaneously. And that allows us to select and extract relevant information. So now we've processed our signals. Now we need to know where those signals were recorded, and we need to be able to visualize those through time. What we're looking at here is 2 MRI images. We did this with postmortem MRI imaging, and what I'm showing on the left-hand side is an axial cross-section of the animal with all of the electrodes placed, and on the right-hand side, we have a high-resolution image of the heart. We're going to step through each one of these images, and I want you to note that on the torso surface, or that upper surface of the animal, we're going to be seeing these little Christmas tree lights show up, and those are the torso surface electrodes. And then we're also going to be seeing these little daggers poke through the heart. And that corresponds to the intramural plunge needle arrays that we would see. So we're going to scroll through that now. Great. And now we're going to look at the same heart in high resolution. This allows us to get really precise locations of the intramural plunge needle arrays and the overall cardiac anatomy. As we're seeing, we're stepping through here. We're again seeing, it looks like there's a little lag, and I apologize for that, but we'll see these little daggers show up. And those are corresponding to the intramural plunge needle arrays, as shown. We then take these MRI images and we process them using our open source software called Seg3D, and these segmentations are then registered, and the electrodes are placed in these 3D computer models to allow us to visualize the data throughout time and space. The final component that we really wanted to highlight was we needed to be able to control acute myocardial ischemia. Specifically here, we used, again, the hydraulic occluder placed around the left anterior descending coronary artery that we could then vary the amount of perfusion that goes to regions of cardiac tissue. In order to stimulate the heart, we could use right atrial pacing to increase the overall heart rate, and we could also infuse the drug dobutamine to increase the overall cardiac activity. What we end up with at the end of this aim is, as seen here, just the epicardial recordings, but again, recordings across all surfaces, a complete control of ischemia here. So again, to summarize, the requirements of our translational comprehensive model of ischemia was first, to measure from the needle, sock, and torso simultaneously. Second, to get precise locations of those electrodes. And then third, to control acute myocardial ischemia. So now that we've created this experimental model, we get to put our scientific goggles on and actually use it to answer some important scientific and clinical questions. So the second aim was to test the hypothesis that exercise and dobutamine infusion create different regions of myocardial ischemia. In order to understand this aim, we need a little bit of background in terms of what are we talking about exactly here. So when we think about those cardiac stress tests that we talked about before, we had 2 primary types. We had exercise and pharmacological. In the case of exercise, exercise actually has some pretty complicated effects on your body. But in the end, exercise leads to an increase in overall heart rate and cardiac output. Dobutamine stimulation is equally as complicated and works through a series of different pathways. As we administer dobutamine, dobutamine acts specifically on this beta-1 receptor highlighted in red. And that beta-1 receptor then goes through this complicated biochemical cascade that leads to an increased heart rate and contractility. Previous studies have shown that there's a variable sensitivity and specificity using different stress types, i.e., sometimes dobutamine is more sensitive, sometimes exercise is more sensitive. However, these studies were limited because they only had clinical measurements, such as those 12-lead ECGs, and they were missing that high resolution component that we could provide. Therefore, the question still remains, is the electrical ischemic signature different for exercise and dobutamine cardiac stress types? So to test this, we're going to use the experimental model we developed in both exercise and pharmacological stress tests. Specifically, we again induced exercise using right atrial pacing, as shown here. And we also induced with dobutamine infusion following standard clinical protocols of infusion of dobutamine. For the pacing, we induced increased heart rates based on what average increased heart rates occur for patients inside a cardiac stress test. What's important about these stress tests is they're broken up into 15 minutes each, and they're broken up into 5 stages with 3 minutes per stage. During that stage, exercise or drug infusion is held constant. So once we have the general protocol of what we're going to do with these animal experiments, we then need to go ahead and do them. And so specifically, we again recorded within the myocardium on the heart surface and on the torso surface. And then we extracted data from each of the individual stages of the interventions, i.e. at the end of stage 1, end of stage 2, 3, 4, and 5, as highlighted here by these arrows. And what were we tracking? Again, we talked about changes to the ST segment and specifically the ST40. And we were tracking that potential and how that changes over time. As you can see here, there's an individual electrode. And you can see that the ST40 changes throughout the ischemic intervention as we progress from blue to red. Now, another unique part about our experiments was the overall length. Our experiments were extremely long, therefore the experiment timeline was in hours, but the individual cardiac stress tests were only 15 minutes. Therefore, we could perform multiple tests on the same animal experiment in order to determine if there were any relative differences between dobutamine and pacing in an identical animal model, again, with adequate rest in between each one of these interventions or simulated cardiac stress tests. So now that we've laid the groundwork, let's look at some example data that we acquired during one of our experiments. Specifically, what we're looking at here is the intramural, epicardial, and torso potentials. As you can see, we see it across 2 slices of the heart, specifically S1 and S2, and the red and green hues correspond to changes in the ST40 potentials that we measured from each relative zone. The time point we're looking at here is the simulated exercise stage 5, and we're going to compare that in the same animal with a dobutamine stage 5. And what I want to note here is that they don't look entirely the same. And in fact, dobutamine seems to really dissipate in its overall potentials at stage 5. Now, this is just one example. So obviously, we need to look at this across all of the interventions that we did and determine what kind of metrics we can do to determine how similar these different types of interventions are. And we started first with relative comparisons. Specifically, we're talking about comparing a dobutamine intervention to a simulated exercise intervention within the same experiment. And we have 2 relative metrics that we can use. The first one we used is called spatial correlation. Spatial correlation essentially uses a normalized metric from -1 to 1 that tells us how alike the patterns of electrical potentials that we measured, or ST40 potentials we measured, are across a surface at a specific point in time. With 0 showing no correlation, 1 being perfect correlation, and -1 being the opposite correlation. We also used a dice overlap coefficient. We used this specifically in context of the volumes that we created, because we want to know whether or not a volume of ischemia over here overlaps with the volume of ischemia over here in the dobutamine versus pacing, or versus simulated exercise. Therefore, the dice overlap coefficient again gives us about a normalized value from 0 to 1, with 0 being no overlap and 1 being perfect overlap. We also compared some absolute metrics. We're going to start with the thresholded volume. Specifically here, first, we have whether or not the volume of measured intramyocardial ischemia is different compared to one intervention versus another. We also compared the number of clinically positive electrodes on the epicardial and torso surfaces. This is set by clinical threshold cutoffs, and we just counted the number of electrodes that identified ischemia, as shown here. And then finally, we looked at this thing called gradient amplitude. It's a little bit difficult to explain, but if we think about that transition between healthy to ischemic tissue, or blue to yellow in this example here, we would think that the progression in this figure would be relatively small, i.e. the gradient amplitude would be relatively small. However, in this example below, you can see that there's actually a rapid transition between the healthy to ischemic tissue. And here we would indicate that the gradient amplitude is significantly larger. So we're going to examine all of these thresholds or all of these different metrics in the coming results. First, we're going to look at the spatial correlations. And again, what we're looking at with the blue line is comparisons of identical stress type comparisons. So these are spatial correlations of identical stress types, like dobutamine versus dobutamine within the same animal. And as you can see, those stay relatively high, somewhere around the 90% range. But when we compare different stress types, again, in the intramural domain, we see that it decreases down to around 50%. This happens again on the epicardial surface. You can see that significant decrease, now down to around 10%. And then finally on the torso surface, we also see this. What's important to note is that we see this occurring towards the end of the intervention. Specifically, we noted that this was occurring around stage 3 of each individual intervention. Next, we looked at that DICE overlap coefficient. So specifically, we're looking at the volumes of ischemia and how much they overlap compared to one another. And here we would note that there isn't as much change as we would see as we saw in the spatial correlations, but there still was some significant difference. And again, we would highlight that at around stage 3, the DICE overlap of these different stress type comparisons decreases to below what we would expect in terms of moderate or decent over DICE overlap coefficient. Next, we move to our absolute thresholds. Specifically, first, we looked at volume. And when we looked at the volume, we actually found that there weren't any real significant differences between the dobutamine and stimulated exercise interventions. But when we looked at the number of clinically positive electrodes, especially on the epicardial surface, we noted that there was a significant increase in simulated exercise compared to dobutamine, especially towards the end of the intervention. However, this didn't propagate to the torso surface quite as we expected. This could be due to the torso surface having some issues with noise and not using the right clinical cutoffs, considering this is an animal model and not the human model. Again, this on the epicardial surface, we would note that this occurred later in the intervention around stage 3. Then finally, we looked at these gradients. And what I want to note here is that these gradients in simulated exercise stayed relatively consistent, if not increased, throughout the interventions. Whereas in dobutamine, that actually had a tendency to decrease, specifically around stage 4 of the interventions, with a significantly large difference between simulated exercise. So in summary, there were significant differences in the spatial correlation, DICE overlap coefficient, and epicardial clinically positive electrodes that became more pronounced at the end of ischemic intervention. There were also significant differences in the gradient of ischemic potentials, with simulated exercise having significantly larger gradients of potentials. And then third, there was no significant difference in measured intramural ischemic volumes. So I want to highlight these first top two, and I want to think about this first in the context of putting our clinical hats back on. What could this possibly mean in terms of our clinical interpretation of these test results and routine test results that are done in the clinic? So jumping back to this figure here, in the case of the epicardial and torso potentials, there are significant differences between the dobutamine versus simulated exercise. And these significant differences show up as the dobutamine stages having relatively less potential or less ischemic potentials compared to the simulated exercise. And, you know, I think it's important to recognize that as scientists, we kind of want to know that these are important clinical implications, but what is going on? So putting our speculative scientific goggles on here, let's go back a little bit and talk about acute myocardial ischemia. Specifically, acute myocardial ischemia can cause, and there's significant literature showing that it causes coronary microvascular dysfunction. Now, what is coronary microvascular dysfunction? I think the easiest way for me to explain it is watering your lawn. So if you had an automatic hose that watered your lawn, as your lawn got more and more dry, the hose would increase the flow to that region of your lawn and water it better. However, with coronary microvascular dysfunction, if your hose had coronary microvascular dysfunction, it would actually, rather than water your lawn more as it got dry, it would water it less as it got dry. So in context of the heart, this would be like some region of the heart becoming ischemic. And then subsequently, as it becomes more ischemic, there's less and less blood flow that goes to that region. And ischemia is known to cause coronary microvascular dysfunction by increasing the vasoconstriction throughout the ischemic episode. Now, how does this feed back into what we're seeing in terms of simulated exercise and dobutamine stress tests? Well, it's important then to look at what dobutamine is even doing. We know that dobutamine has a prominent effect on beta-1 receptors that cause increased heart rate and contractility. However, it also has effects on beta-2. And beta-2 causes increased vasodilation. So these effects of dobutamine, which beta-2 effects happen at high doses of dobutamine, may actually be canceling the effects of coronary microvascular dysfunction, subsequently leading to this change in overall gradient amplitude that we noted in our data showing the differences between ST elevations and ST changes in the intramyocardial wall. So therefore, in this second aim, we tested the hypothesis that exercise and dobutamine infusion created different regions of myocardial ischemia, and we found there were significant differences between those regions of ischemia, and we speculated that it could be because of some sort of coronary microvascular dysfunction. In aim 3, we're going to assess the transient recovery of ST segment deviations on remote recording electrodes during partial occlusion cardiac stress compared to intramyocardial ST segment deviations. And this is a mouthful, so we're going to start by again putting our scientific speculative goggles on and thinking about these interventions that we're seeing. So when we think about the intervention that we create, we have here the start of the intervention and the end of the ischemic intervention. And as we progress through that intervention, we increase the cardiac stress over time. Therefore, if we were measuring changes to the ST segment, we might expect that over time, we would see a significant increase in the ST segment potential values that we measure over time. However, when we looked at our data, we found some surprising results. In fact, that on the epicardial sock, as shown here, the ST40 potentials come up and then start to drift back down. This was really odd to us, and so we looked on the torso surface as well and found similar findings. So the question was, is this real and what's really occurring? So we took some examples and we examined that at baseline, we have relatively low or small amounts of ischemia. At peak, we have significant amounts of ischemia. But at recovery in the end, again, shown on the torso surface and epicardial surface, we have a significant recovery. However, in the intramural space, there's still something weird going on. So we've got to quantify this across all of our experiments and all of our interventions. And specifically, we did that by first looking at the timing of these peaks and recovery of ST40 potential that we're going to call ST40 recovery going forward. So we see here that we marked the peak and the recovery where the electrodes drift below that threshold line as shown in the black dotted line, and we determine the average recovery time and the average peak time. Here we see the average ST peak time around 4 to 5 minutes within the intervention. And we see that the recovery or ST40 recovery time occurs somewhere between 7 to 10 minutes into the intervention. For those of you that do animal research, this is a surprisingly consistent result across both different varying types of interventions, both simulated exercise and dobutamine, and across a series of different animals. So we then looked at the number of clinically positive electrodes on the sock and the torso surface. And we noted these similar patterns. In fact, the baseline levels were extremely low that jumped up to around 90 electrodes and then came all the way back down to almost baseline levels and then increased a little bit towards the end of the intervention. That was replicated on the torso surface as well. So we had to take a moment and really dive into the literature to try to understand what is going on here. What could be a possible mechanism that is causing this significant ST40 recovery that we're seeing? And when we examined some of the literature, we found some interesting results from previous work that showed that there's some type of, during full occlusion ischemic events, there's some type of change to the cells. So going back to our physiology, here are two cardiac cells or cardiomyocytes, and they're able to propagate electrical current really, really fast, which allows that heart to contract the way that we would expect it to in a coordinated fashion. And they do that because of these things right here that connect these two cells called gap junctions, highlighted here in yellow. These gap junctions are like gigantic pores that allow a bunch of current to flow through them relatively quickly. Now, in the case of ischemia, there's actually some gap junction uncoupling. Specifically, we see here, they don't actually physically separate, but for the sake of this argument, they separate and uncouple, which prevents electrical current from flowing. Now, going back to our measurements of ST40 potentials, we know that that's a flow of current from healthy to ischemic tissues. Therefore, if there was no electrical current flowing or significantly reduced electrical current, we would expect no changes to the ST40. And subsequently, that could be what's driving this whole phenomena that's occurring. Now, if we have cellular uncoupling occurring within the heart, that's a pretty significant phenomena. And we're probably going to see it in other parts of the electrical activity. Specifically, we're going to see slowed cardiac conduction velocity. And using some of the work recently published and perfected by Dr. Wilson Good, we were able to calculate the three-dimensional conduction velocity within the myocardium and decompose that conduction velocity to overall speed, conduction speed. So in the case of what we're thinking here, again, propagating through this intervention, we would expect that conduction speed was initially start at baseline at relatively high, decrease at peak, and then continue decreasing throughout the ischemic intervention, indicating that that uncoupling is occurring. However, when we looked at it, it's really not what we saw. In fact, we saw a significant recovery of these potentials, or of the conduction speed at recovery, which indicated to us that cellular uncoupling is probably not what's causing these decreases in overall ST potentials. Now, we noted in the beginning that there was some changes in the intramural space that we weren't entirely sure what was going on. And what's unique about our experiments is we're able to look at that intramural space in high resolution, as shown in these images. And really wanted to look at this again across time throughout the intervention. And what we saw is that the proportion of total volume that was ischemic in the intramural space went up to around 40% at peak, but then only decreased to just below 30%. That indicates that there's still some significant ischemia despite all of these signals telling us that there isn't on the epicardial and torso surface. So what exactly is going on in the intramural space, and can we think about this in any more sophisticated way? Well, with our computational models, we're also able to take this subsection and then determine how close parts of the wall or parts of our recordings are to the outside of the heart and the inside of the heart. Specifically, we're looking at the transmurality. And this is a known phenomenon in acute myocardial ischemia, in that ischemia may develop on the subendocardial region or subepicardial region. So to mimic that, we broke our models into three different components, these intramural components of first the subendocardial region, the one closest, the third closest to the endocardium, the subepicardial region, the one closest to the outside of the heart, and then the mid-myocardial region, or the one in between the two. When we look at the subendocardial volume and mid-myocardial volume combined here in this image, we see that the baseline, we initially get a peak, and then it follows that similar trend that we see with the total volumes. However, when we look at the subepicardial volume, we see that initial uptick of overall activity and then a significant downtick at the recovery point. Again, indicating that the subepicardium more preferentially recovers compared to the subendocardial or mid-myocardial regions. So to summarize the results that we just discussed, there was a repeatable rise then fall of measured ST40 potentials on the epicardial and torso surfaces in both dobutamine and simulated exercise interventions. This decrease in ST40% was not related, at least in our inferred way of looking at it, to cellular uncoupling as evidenced by the recovery and conduction speed. And then finally, the subepicardial region recovered significantly more than the mid and subendocardial regions. Now again, putting our clinical hats on, it's important to interpret these results as to what would we expect clinically and what's going on. Again, assuming that we're increasing cardiac stress this entire time, we see that a significant increase in ischemic potentials followed by a decrease. And that's got to be a little unnerving as a physician to think that we could be increasing ischemic load, we could be seeing ischemia present in the heart tissue, however, we can't see it from the torso surface. And this is just another kind of tick in the hat in terms of noticing this silent acute myocardial ischemia or ECG silent ischemia that has been commonplace or seen commonplace through clinical medicine. So we also need to put our scientific skeptical goggles on and think about what could possibly be causing this and how could this possibly be happening. So putting those goggles on, we can think of, we're going to go back all the way to the cell and we're going to think about cell action potentials. Specifically here, we look at a normal action potential and an ischemic action potential. It's important to note that there are significant differences between the two, and those differences are what drive current between healthy and ischemic tissue and subsequently manifest as changes to the ST segment. Now, there's significant literature that shows when your heart is stressed, it releases catecholamines. And in context of the catecholamines, an ischemic cell with catecholamines induced or provided to it will actually change its action potential to meet more of the normal action potential as shown here. In that case, we would then get significantly less current flowing, and subsequently the ST segment potentials would be decreased. Now, this is really interesting, but why would it only be happening in the epicardium? And in order to think about that, we need to think about our coronary vascular anatomy. And we're looking here at a cross-section of the heart. And what's important to note is that vessels of the heart flow on the epicardium, then dive to the endocardium. If you have a systemic release of catecholamines, like you would in this case, in the case of ischemia, the initial diffusion of catecholamines would be relatively large. But as you progress down towards the endocardium, you would get a significantly less diffusion as we progress downwards. Now, why is this important? Because in the end, what we're really picking apart here is that ischemia is thought to be a perfusion-based change, but we're highlighting here that the perfusion is missing a key component in the catecholamines may play a key role in terms of how we view this subendocardial ischemia development and what's exactly happening. So in conclusion, I want to just summarize this body of work is that we took an experimental model and created one wearing our engineering hats, and then took our scientific hats and our clinical hats to interpret some of these results from these experimental models to provide meaningful insights in terms of how things are developing with ischemia and what develops over time through an ischemic intervention. The hope being that as you come in with chest pain, we can accurately diagnose you and get you as quickly as possible back out on your bike, riding throughout the entire campus and wherever you ride your bicycle. At this point, I want to take a moment to thank all of my funding sources and some of the people that have been involved. I'm not going to, can you please just stay with us after this question and answer period? I'm going to do a very special discussion of all the people that have helped me with this project. But right now I will take any questions.
Okay, so you can let us know, Jake or Lindsay or I can unmute you if you want to pose a question. Either,
Yeah, so it looks
Yeah.
like Ben has a question, so I'll go ahead and ask him to unmute. Ben Steinberg. You should be able to unmute yourself.
I was just applauding.
Oh, that was the applauding.
And you don't have a question, Ben? Come on.
Ah, those are the clap emojis. I thought it was the raise hand emoji.
Ken Spitzer has a question.
Okay. I just want a great job, Brian. Geez, I remember when I first told you about action potentials in the classroom. So come a long way. This is great. But I have a question. Why would you think that conduction slowing would affect the ST segment? I mean, I think the usual dogma is the ST segment results from sort of during ischemia as steady state differences in depolarized tissue interacting electrotonically with normal tissue. And the depolarization is often caused by a local accumulation of potassium in the ischemic zone. Maybe I just misread what you said, but I thought you were suggesting that a conduction velocity slowing could contribute to ST segment. I'm not sure how that would happen.
Yeah, my apologies. That probably wasn't ultra clear. Just to clarify, I'm not necessarily suggesting that changes in conduction velocity equal changes in ST segment changes. Those are kind of disjunct things. It's more the fact that cellular uncoupling could cause changes in the current flowing between healthy and ischemic tissue, right? And a manifestation of identifying cellular uncoupling would be changes to conduction velocity. So kind of inferring cellular uncoupling through conduction velocity, if that makes sense.
Okay. But another thing, so in summary then, are you suggesting that that there's the sensitivity of dobutamine versus an exercise test, the thinking clinically, globally, that there are differences you're likely to see in an ischemic, in a patient that has coronary vessel disease, you're likely to see a different response to dobutamine versus exercise. Is that right?
Yes. For
Okay.
all of these clinicians on the call, that might be.
That's really
Yep.
important, by the way.
Yep.
I mean, so which, just excuse my ignorance, so which are you, can you suggest which one is more sensitive?
Right. So I think in this context, it's important to note that dobutamine stress testing is commonly performed with an echocardiogram as well. And that's the ultrasound where they're measuring heart function. And we didn't perform echo in any of our experimental models. So in terms of determining whether or not dobutamine versus exercise is a more sensitive test, I can't answer that question directly. But what I can answer is if you're just recording electrical recordings, what is the more sensitive stimulation mechanism? And in our experiments, we showed that the more sensitive stimulation mechanism would be exercise stress.
Okay. Of course, just pacing the heart at a higher rate is not the same physiologically as exercise.
Absolutely. And that's definitely a limitation of our studies in that we can't perfectly emulate exercise. We can't imagine very many animals will be happy waking up
Right.
and
No,
exercising for us.
obviously you can't do it, but no, I'm not criticizing, just to point out that,
Yep.
that afterload and all kinds of things change.
Absolutely. Yep.
Exercise. Okay, great. Thank you.
Thank you for your question.
Okay, are there other questions? I think everybody wants to get to your thank yous, Brian. You've created
Awesome.
a great deal of suspense.
That's great. I'm glad I built up suspense. Okay, we good to move on?
Seems like it.
Awesome. So I want to start out this by taking I'm going to call it a journey of thanks, because I want to describe like how I got here and all of the privilege that I've been afforded to get to where I'm at, and all of the people that have helped me get here. And so I got this picture. This is me when I was 15 with one of my friends. And I guess fundamentally the question is, one, how did I survive all of the events that took place here? And then two, like, how did I get to this point where I'm standing up in front of you all having a really great discussion about some complicated science? And I want to say that it all started with high school calculus class. Started with two people in specific, Rocky Lamborn and Adela Croft. These were my two calculus teachers in high school. And they assigned me a writing project in math class. And I didn't understand why we had to do it. And they said, you have to interview somebody who does math in their real life and like talk to them about what it's like. So I got to interview this guy. His name's Austin Hill, and he was a biomedical engineering graduate from the University of Utah, about what it was to be a bioengineer. I think at that point, I just kind of fell in love with it and somehow got really, really lucky in terms of my whole undergraduate experience. And obviously, it starts with Rob. I mean, first, I hated bikes before I met Rob. And that's no longer the case for anybody that knows Rob. I feel like if I've been here this long, I have to own a bike and like riding it. But also the undergrad research team from the Karma Center that allowed me the opportunity to really to just kind of grow and expand, including Dr. Marush, Nathan Bergen, Fred Hahn, and Alan Morris. I also really want to take some time and thank my PhD committee members, specifically Dr. Saxey, Dr. Ranjan, Dr. Sharma, and Dr. Timmons. Out of this group, I've been working on research projects. I've done 2 lab rotations in Dr. Ranjan and Dr. Saxey's lab, and also worked with Dr. Sharma on research projects. Dr. Timmons, you're the only one that I haven't like actively collaborated and engaged with. But I also want to highlight that in addition to like these key people, I had other really amazing mentors, including Dave Granger, Will Deere, Rashmi Shah, Eugene Komolsky, Ken Spitzer, who's on this call, Dana Brooks, Ben Steinberg, and Jared Bunch. And I also, you know, it takes, it's not even a village at this point, but it takes like a massive university in order to really help someone go through this PhD process and grow and develop. And the opportunities I've been given are just absolutely spectacular. I also want to take the time to thank the program that I'm involved with. The MD PhD program here at the U of U is absolutely one of the best things I ever did. I didn't know that I wanted to apply for an MD PhD until about 2 months before I applied. And then I got the call that I got an offer from Gab Cardin at the time. And I remember just being ecstatic. And I accepted right away and never looked back. And I really enjoyed my time. I also want to thank all of the amazing people at CVRTI and the Ski Institute. I think sometimes we gloss by the fact that there are amazing staff that help us as PhD students get to grow and learn without, and they just like guide us through the process in so many important ways. So specifically, I want to thank Jane Davis, who taught me most of my surgical skills, Alla Booth, and also Bruce Stedman, who helps us with all of our equipment. I want to thank the people at Ski as well, including Nathan Galley, Ed Kask, Deborah Broughton, Chris Pickett, and then some software developers at Ski, including Ali Warner and Dan Ski Run Man, who's on the call currently. I also have to take some time and thank all the members of the lab that have been with me through this journey, specifically Dr. Brett Burton, Dr. Wilson Good. We have Jake Bergquist, who's been absolutely spectacular, Lindsay Rupp, and Dr. Jess Tate. And then finally, just thanking Rob. I mean, really, somehow Rob has put up with me for the past 10 years and not like thrown me out. At least I feel like he did multiple times, but it's okay. We don't have to think about that. But it's been a really spectacular experience, and I couldn't ask for a better mentor in this process. I think it's also important to note that like throughout all of this, I do have a life, and I do enjoy getting to know people and having friends and developing friendships with so many different people with unique backgrounds doing different things and working on different projects has just been absolutely pivotal in my overall development. Wouldn't go without saying thanking my family, both family that I've married into and also my own personal family, including the undying support from my mom and my sister. And then also my dad, who's no longer with us. I think he would be proud at this point of me. He would definitely ask, why are you doing research? That was not his thing. But he would be proud of me nonetheless and supported me 100% in doing anything that I was doing. And then the final kind of person I have to thank is my partner in crime. Here it's now turned into 2 partners. We got a COVID puppy. So this is also Lucy here, but my partner Aaron really has just been with me through everything. We met each other in high school, and it's been a really fantastic journey. And I'm so glad that I have everyone's support. And finally, thank all of you for coming and joining me and staying